Hello and welcome to our lecture related to review of the traumatic brain injury case that was presented in OWL last week. We're going to be going over the different categories that are relevant for us as presented in the table related to Marie, who unfortunately suffered a traumatic brain injury. We're going to be looking at her presentation across these categories over different periods of time. So if we start at the 6-week mark in regards to the admittance to acute rehab, so this is 6 weeks post-trauma, let's appreciate that the different categories would be cognitive, neuromuscular, swallowing, and communication. And that's done on purpose. If you were a healthcare provider and a member of a team in the acute rehab setting, in the community, involved in the care of an individual, of a patient, its odds are that there's going to be categories such as these that are highlighted within the patient's chart. Now, depending on your role in the team, this might be particularly your area of interest. For example, swallowing or communication would be in speech-language pathology. Neuromuscular leads more towards physiotherapy. That said, some things definitely overlap. Cognitive is relevant across many different areas of the field. So even if it's not per se your area of specialization for care, being aware of the findings in each of the presented categories that you might read in a patient's chart will be relevant in how you approach and how you care for the patient. The patient's ability to understand cognitively, participate in their care neuromuscularly, be able to eat safely and swallowing, and communicate with you all are clinically relevant. At the 6-week mark related to Marie, appreciating category by category from a cognitive standpoint, at this point in time, she has the ability to open her eyes, and there is the presentation of some random movement. Able to blink eyes when startled, not able to track to auditory or visual stimuli. And she does not respond to verbal commands, and she does not vocalize or make any attempt to communicate. So her ability to engage and interact with the outside world is significantly limited. For individuals involved in her care, as a result, they'll have to try to cue into other findings beyond active engagement, where she's still, unfortunately, at this stage, cognitively compromised. From a neuromuscular perspective, we can appreciate that there's abnormal tone and varying levels of strength in both the arms and the legs. And as a result, she requires full assistance to roll in bed and transfer from bed to chair. She also requires full assistance to sit at the side of her bed, and this might be called a full assist, meaning that she's not going to be safe if she's sitting there to the side. If she is to be there at the side, someone will have to hold her vertically. Now, that said, there is sufficient muscle tone that she only requires minimal assist to maintain her head control. And that leads a little bit more to an appreciation of, at this stage where cognitively and neuromuscularly there is a compromise that is still distinct, well, why do we make the effort to help her with sitting up in a full assist transfer in the first place? And that answer would be a multitude of different things. Let's consider first off lung health. That's a broad category. We're talking about things like pneumonia or other things that can be incurred. And also, if you consider how your lungs change when you're vertical versus horizontal, still having the ability to mobilize and attempt to bring in some oxygen in a seated position would be of benefit. Circulation is also of concern. The short form you see there, DVT, is short for deep vein thrombosis. Another term related to that, blood clot. And it's of concern that if a blood clot should develop in the human body, and that's sometimes secondary to trauma, that's sometimes secondary to inactivity after a period of time, and Marie is presenting with both phenomenon, then if a clot should develop, for example, in the leg or the arm or the lung, then the risk that it might travel elsewhere to cause further harm, such as an ischemic stroke, is present. If we can go vertical, we're going to alter blood flow, we're going to reduce the likelihood of that. So attempting to prevent that is one other feature. We've discussed before in the previous lecture related to spinal cord injury, the concerns related to contractures as well as pressure sores, and these are not limited to spinal cord injury themselves. A contracture can also develop in other neurologic presentations. We know she has abnormal tone. We know her ability to move in bed or sit to the side is significantly limited. So there is the potential possibility that her limbs may not move as much as they should, and she could develop a contracture. There's already the presentation of sores noted in the case, and for that reason, although it is a full assist to have her sitting at the side of the bed, there are multiple medical reasons for us to attempt to do so, especially if there's already the presence of these stage 3 ulcers. Just remaining in bed, it's just going to worsen the skin breakdown in the region. So altering position to prevent some issues, as well as to try to address other ones, is clinically relevant. Further to at the 6-week mark related to our acute rehab, she is working with speech pathology for dysphagia. And again, dysphagia would be altered swallowing pattern. And although in the early stages she's reliant on a G-tube, that does not necessarily mean that you can't already begin to do some swallowing training if you're working in conjunction with the speech language pathologist. That said, communication at this point in time is not possible. So moving on to the 13-week mark, Marie is still in the rehab setting, but she has made some positive changes in the realm of these different categories. Now, cognitively, she's able to interact and engage with her environment a little bit more, which is good, but this is also where you might pick up that there have been some changes or differences present. For example, she now exhibits short-term memory loss, and from her interactions over time, you might find that there's also an inconsistent presentation of disorientation. She's unaware of place and time, although consistently aware of who she is. This might relate back to the traumatic brain injury, or just the fact that being in an uncertain environment in conjunction with traumatic brain injury can also influence disorientation. Testing for orientation of person, place, and time is something that's frequently done, for example, related to sports. If you're playing hockey, rugby, football, and you should take a hit and you're concussed, the trainer may then, once you become unconcussed or able to engage, they may ask you, okay, do you know who you are? Do you know where you are? Do you know what the score is? Do you know what quarter it is? And although it's not the best measurement related to cognitive ability, it does give us a chance to appreciate how well the person is able to actively engage with their surrounding environments. Again, Marie can now actively engage more, so that could lead to some positive changes for her further rehabilitation, but we have to be aware of how cognitively she still may be compromised. Case in point, she can follow 2- and 3-step commands, but when it comes to a closed environment, that's where she tends to excel more. Otherwise, she can follow 1-step commands only. So as we discussed related to traumatic brain injury in that lecture, distraction from surrounding environment can be a possibility. So if she's in a closed environment, meaning if she's in, for example, her hospital room, you could say to her, Marie, can you reach over, grab the plate on the side table, and hand it to me? And she could do that. But if she had to do something similar in the outside environment, where there's greater amounts of distractions, she might be only limited to, she can reach for the plate. Now, this leads further to an appreciation that because she's easily distracted, she can only attend to tasks for 5 minutes at most at the time. So if you're a rehabilitation provider, whether your role is occupational therapy, physical therapy, speech language pathology, whether your focus was on direct nursing care, physician care, whatever it may be, your ability to be effective is within a limited timeline. And depending on the environment you're in, your ability to provide education will be limited to only 2- to 3-step commands if you're fortunate. So being aware of one's cognitive status in Marie's case will provide you a better opportunity to succeed as long as you limit the steps and limit the time. From a neuromuscular perspective, she's now able to exhibit full and close to normal strength and range of motion in her right arm and leg. There still seems to be some increased tone in her left leg only. Further related to the neuromuscular, she has impaired coordination in all 4 extremities. And as a result, there's going to be some further limitation in terms of her physical interactions with her environment. Now, she has progressed to the point in time where she can sit independently, and she can react to challenges in her dynamic balance. Now, what that would mean is if she should get up and pushing up, she leans somewhat to the left and feels that she's going to stumble, she can right herself. She can control for that. Or if she's moving past someone, a family member, or otherwise accidentally bumps into them, she can again catch herself. So she's able to do that. And she can stand with the use of her own power, minimal support for about 3 to 5 minutes, and can walk on level ground for approximately 10 meters, or a little bit more than 20 feet, with moderate assistance and gait aids. Now, the difference from minimal to moderate is, of course, a little bit variable, but by argument, minimal would be where somebody is there, maybe providing verbal cues or a light touch or both, just so that you can stand supported for that period of time. However, the amount of support needs to be increased, likely physically, when she's attempting to walk, and that's probably further explained by the need of a gait aid. Now, gait aids can be starting off with a 2-wheel or 4-wheel walker, or you might need to just go with a standard 4-leg walker if she needs more support, and over time, she may be able to reduce to the use of a single cane. Swallowing at this point in time is still a reliant feature where we're reliant on the gastrotomy tube, meaning that she still is not at the stage where she's able to eat food safely. The dysphagia that's present will put her at greater risk of food going, instead of down the esophagus, down into the trachea, down into the lungs. Again, risk of pneumonia, as we've discussed about in previous lectures. Speech pathology is likely going to be involved further in swallowing pattern training, as well as now addressing communication issues. She's starting to exhibit some expressive aphasia, in which she can make her basic needs known using some verbal language, but she is struggling in terms of word retrieval deficits. But she's receptive to normal language skills. So if you talk to Marie, she can understand what you're saying. But in terms of her ability to generate words, this is where she has challenges. This is an example of Broca's aphasia, which we discussed in our second lecture related to stroke. We are now at the 5-month mark, or 20 weeks, and Marie has been able to progress to home with the care of her husband. She still will come back related to rehabilitation, but that's in the day hospital environment, meaning that she'll arrive to the hospital, be there for a certain section of time of rehabilitation, dependent on who she has to see. She might see speech language pathology, occupational therapy, physiotherapy, and related to the care of different individuals, she might be in hospital for 2 to 4 hours. Within that period of time, she'll be working on various tasks and goals. And we can see further progression related to her recovery at the 5-month mark and the role of her cognitive presentation. She's now oriented to person, time, and place at all times. And although she's shown some improvement in short-term memory and some new learning, it's still impaired, meaning that tasks can be picked up a little bit easier, but repetitions are more likely still to be needed than for someone who hasn't experienced a traumatic brain injury, as well as there can be some further concerns related to distractions. Now, she can follow a 4 to 5 step command. That's beyond 2 to 3. But again, performs better in the highly structured environment, coming back around to the concern of distractions. Now, in an open environment, she still is easily distracted, needing verbal cues. And this is where the individual with a traumatic brain injury can describe that they just feel overwhelmed. Areas that have higher traffic flow, more things that are going on, it's very difficult for them to identify where they are in this environment and what they are attempting to do. As a result, her safety awareness is still a little impaired. It's improved in the sense that there can be a bit more independence, but that is to a limited extent. And where Marie is, what kind of environment she's in, is very relevant. Continue on with neuromuscular. We can appreciate that her muscle tone has improved. It's now normal in all 4 extremities. She is a little weaker on that left side. So what, presented with some tone changes, still is showing some weakness. And this may be an ongoing issue further in the future, where we're now at the 20-week mark, and it still seems to be a long-standing issue. Now, her coordination has also improved, and it's better with slow movements, worse with fast. Still a problem in all 4. It makes sense that if someone's trying to perform a coordinated activity, we tend to do it slower to begin with. And by doing so, post-traumatic brain injury, Marie is able to build into her pattern effectively, but there still is some challenges related to performing a task faster. Moving further into the neuromuscular presentation, Marie can now normally roll in bed, lie to sit, and do so independently. And when she's sitting independently, she demonstrates normal dynamic balance control, and that's also found not only in sitting, but also in standing. So she has now better awareness of how to actively engage her muscles in conjunction of an awareness of where she is in space. Now, although that's improved, we have to keep in mind that there still is some need of support. She still requires some supervision when transferring from bed, and moderate assistance to transfer to standing. Now, some of this, for the supervision in transferring from bed, may be a matter of safety. And again, cognitively, her awareness can be limited at times. The moderate assistance to transfer to standing is such that you got to look at the activity. Sitting, she's independent. Once she's standing, she's independent. But going from sit to stand requires not only muscle strength to do the task, but controlling your center of gravity and keeping your center of gravity within your own feet. She may require that moderate assistance to make sure that she doesn't tilt too far forward and become a fall risk. Now, at home, because of the need for further independence and progression, it's probably been isolated that if she wishes to be independent, it is safest to use a wheelchair. She can walk inside the home with supervision, again, for safety, and this is where we might need ambulatory aids, but outside she'll require even further assistance. And this plays into the aspect of how your ability to do things from a neuromuscular perspective is also attunely connected to your cognitive ability. We can have somebody who has improved strength, range of motion, even balance coordination, but if they are easily distracted, or if their ability to concentrate or even memorize various tasks is compromised, that may further impact their ability to do tasks safely and put them at unwanted risk and harm. Marie has progressed to the point in time where now she can actually eat independently. However, her diet is not what you might deem as full. She's on a soft diet, which means any food that she's right now eating has to be of a certain integrity. Certain things like, for example, a hard apple or various cuts of meat or other things, they no longer can be eaten just as is. They would have to be pureed, or different ideas of food might be selected, all of which, from an integrity standpoint, they're all soft in nature, and that way they're easier to swallow. Also of note, her moderate expressive aphasia is still persistent. It's not to say that over time that area can't improve like some of the other aspects that we've talked about, but it is an ongoing challenge for Marie. So as Marie improves from a cognitive and neuromuscular perspective and wants to engage further in her environment, she'll want to develop more independence. And that's not just physically, that's also within the realm of aiming to lead her life as much as possible. Communication is something all team members have to be aware of in terms of Marie's ability to discuss her wants and needs with others, especially now where she's outside of the hospital setting. And we're trying to find that balance between Marie's safety, Marie's ability to engage functionally as much as possible, and her interactions with family members like her husband, and so forth.